Thanks for the opportunity, Katie. So I'm Dr. Bob Mabry. I'm a retired Army emergency medicine physician. I enlisted in 1984 in October when the Rangers, actually 1983, when the Rangers jumped into Point Salinas Airfield. I was initially, in my first enlistment, Army Ranger infantryman and a plank holder in the 3rd Ranger Battalion, one of the original members when they activated in 84 October, and then got brainwashed and re-enlisted to become a Special Forces medic after I went to Ranger School and made some rank. At the time, I didn't know anything about medicine, but I was also a young single Ranger, and it had the highest, 18 Delta had the highest bonus, the highest attrition rate. And at the time it was in San Antonio, which meant girls, as I was a young single guy. So really enjoyed being a Special Forces medic, was a medic in 7th Special Forces Group on a dive team. And then I was a medic in our Special Mission Unit for 4 years. And so my medic career culminated in Somalia in 1993 when I was a senior medic at the first crash site in Mogadishu. That galvanized me to go on and become a physician. I'd been going to night school, all along while I was a medic anyway. Went to the Uniformed Services Medical School, ended up being president of my class there, and then did emergency medicine residency training in San Antonio at Fort Sam. Went back to First Group as a battalion surgeon, and was with First Group's 1st Battalion that deployed to Afghanistan in 2005. Held a variety of clinical, teaching, operational, and policy roles since then. Worked with the Joint Trauma System and the Institute of Surgical Research. I ran the military's EMS and Disaster Medicine Fellowship, quite a bit of research work on airway and medevac. And then my military career culminated when I commanded the Joint Medical Augmentation Unit, which is JSOC's medical unit. Retired a couple of years ago, and then dropped the mic and tried to do a 1-year around the world post-retirement victory lap, hiking the epic trails of the world, and that was cut short by COVID. And so we were in Thailand in March of last year, and so came back from our travels early, and went into consulting briefly. And my consulting business, just as that was taken off, I got a call from a friend of mine that I worked with in DC, who asked if I wanted to be the number 2 in healthcare in the Pentagon. The Principal Deputy Assistant Secretary of Defense for Health Affairs. So I was briefly a Trump appointee from September until January. And then I left the administration with the new incoming administration, and then started here at HomeFront and have been here ever since. Let's turn it over to Master Chief Viola.
Wow, I don't know. Can you guys hear me? Oh, yeah, I don't know how I can even match that, Bob. That was amazing. So, yeah, so sorry I'm a little bit late. I was having technical difficulty. I was talking to Ricky about it, but now that I'm in, we just doing a background of who we are, Katie? Is that what we're doing?
Yeah, just a short introduction. That would be good.
Yeah, all right. Well, thanks for having us on. My name is Steve Viola. I did 30 years in the world's finest Navy. I did 28 as a Navy SEAL, 26 as a combat medic. I got my bachelor's and master's degree while I was on active duty. My master's from Tufts University, Fletcher School of Law and Diplomacy in Boston. And I had a variety of different jobs that I did in the military. I heard every enlisted rank all the way up to Deputy Force Master Chief, which is like the number 2 in charge of all of NSW enlisted. Was fortunate enough to follow in Bob's footsteps as the SOMA president. I was the vice president. Bob was the president. He stepped down to go to the fellows program there in DC. And then I ended up retiring, started my own business called Max Per Diem Inc., which is to serve with excellence so that others may do the same. And it's basically a medic concierge type stuff for private industries. And then when COVID broke out of last year, Dr. Givens, retired colonel, I believe she's on here as well, said, hey, I need a good enlisted person to keep me out of trouble while I'm in New York. And I texted her back, said, I'm your huckleberry. So we met up there and, met Ricky and Shea and a whole host of others that were there to do the right thing at the right time for the right reasons. And it just really gelled really well. And now I'm the chief of talent at HomeFront Health. And we're looking to really, put a mark on the American public in terms of what the military medic can do, both at, they know what they can do it abroad, but what they can do at home. So I'll stop there. Does that work, Katie? How's that sound good?
Yeah, that's great. Thank you so much. Dr. Givens?
Oh,
She's-
I was going to let Shea go first. This is all about medics. So I was going to let the medics go first and then I'll finish.
All right. Well, hey, everybody. Thanks for joining the call. My name is Shea Stewart. I was a special warfare combatant craft crewman in the U.S. Navy, and I was at SOCM from about 2012 to 2013. Graduated, came back here to San Diego, California, and was at Special Boat Team 12 for 4 years. I out-processed and basically started teaching as my full-time gig all across the country, running multiple different types of labs, working for several different companies, managing all of the logistics and training aspects that they had. Did that for about 5 years. And got the call to go to New York, as a lot of us did. Sort of fell backwards into the opportunity. Really was blessed to get to go out there and be one of the first on ground. Was able to help manage and run some of the staffing and scheduling things we did out there. So through that, met with the folks who wanted to stand up HomeFront Health. They asked me to come on as an operations guy. So I'm currently sitting the VP operations seat here, and looking forward to turning some currently out processing or soon to be out processing medics into medics who can really start to serve and make impacts in their community. And I'm really happy to have the opportunity. So thanks everybody for joining.
And I guess I'll bring up the trail. So I don't have as colored of a history as everybody else. No, I wasn't a special operations medic, but I'm probably their biggest groupie. I'm an emergency medicine physician and spent a lot of my time jumping back and forth from academics to the operational world and trying to help people understand each other on both sides of the fence. And in that process, I really kind of was impressed by, the military medic in general. I just found myself as a physician being supported by medics, bailed out by medics, educated by medics, and really just being able to be a better doctor because of the medics that were at my side. And so it really kind of inspires me to be able to try and create a place for the folks that were doing these things during their military career once they exit the military. It just really frustrated me to see medics who were facing getting out of the military and just had really limited job options, despite the fact that they just done incredible things in their service. And so, New York was a function of that. And I have to, she's not on the call, but I have to thank Kate Rockland for this, her research into what medics are capable of and defining their curriculum and content and all that. That's really what made it all possible for us to put medics in an RN equivalency spot in New York. And so from there, this idea was born of, well, if we can do this here, why don't we do this everywhere? Why don't we find a way to help medics really make a career transition and not have to, move backwards? I mean, there's still always are going to be requirements, different states have different requirements, different hospitals have different requirements. There'll always be hoops to jump through. But if we as an organization, HomeFront Health, can make that transition more efficient so that you can capitalize on your skills and be able to work at a level that's commensurate with your experience and training, that's really, my big goal is to be your advocate and help the world see how capable you are, regardless of what pieces of paper you hold in your hand, to be able to translate the talents that you all hold and be able to carry that forward.
Thank you so much.
Well, so I'll jump right in, Katie. And is there anybody else from HomeFront that's on?
I don't think so.
Yeah, I'll jump right in and tell you about the company. So again, I was just leaving government for the second time when I got a call from the company founder, Jim Sweeney. And so Jim had met Missy and Steve and some of the people that are on the call in New York City. And so Jim is a serial healthcare entrepreneur. He's in his late 70s. And he was a Vietnam era medic. He wasn't in Vietnam, he was in Germany, where as an NCO, he essentially ran a field hospital and was doing all the things that medics could do, suturing, putting on splints and cast and really providing a high level of patient care. We got out of the Army, he came back to the United States, he wanted to be a medic and he couldn't get a job. And so, without going back to school, and this kind of irritated him. So he went on to found a dozen companies, and some of them very well known and very successful. But it always kind of stuck with him that the medics were undervalued. And then so he met Missy and the team there in New York City, and they hatched the idea for this company, HomeFront Health. And so really, kind of underpinning everything that we're doing is the fact that COVID is a black swan event that has significantly disrupted the healthcare industry. The healthcare industry is a $3.5 trillion industry. I mean, it's healthcare cost is about it's a huge amount of our government spending, and then a huge amount of our GDP goes toward healthcare. And I think COVID-19 is forever going to disrupt how healthcare is delivered. And so HomeFront is an extension of that. So if you look at telemedicine, I've been looking at telemedicine in the military for the past 20 years. In the past year, telemedicine has advanced more than the previous 20 years combined. And there's a shift away from nursing homes and assisted living facilities. Obviously, we know what happened to a lot of nursing home patients in New York. About 30% of the COVID deaths are from elderly folks that were in nursing homes or assisted living facilities. And so you have this big wave of aging baby boomers who don't want to go to nursing homes. They want to age in their homes and be as independent as possible. We recognize the need for surge capacity during a public health emergency. And so, it's my position that if you're taking care of patients in their homes that would otherwise be in the ER or in the hospital, you are in fact creating surge capacity, but we just haven't really conceptualized as a country how to do that. Care is more and more being decentralized away from the hospital. And this means that more and more non-physicians are going to be providing higher levels of care. You've heard the term working at the top of your license, right? So PAs and nurse practitioners are going to be doing most uncomplicated primary care. And there's a role for medics there that I'll talk about here in just a minute. We're getting away from fee for service toward more value-based care. And what that means is, insurance companies are going to pay to keep people out of the hospital and not pay for them to go to the hospital and rack up a bunch of charges. And so inherent in that is a focus on prevention and social determinants of health. And all that, frankly, emanates from people's homes. And so we were on a call with a high-level person in the Cleveland Clinic, which is one of our, one of the best health systems in the world. And basically what this person, who's one of their VPs, said that in the not so distant future, they envision the Cleveland Clinic as a place where you get surgery and ICU care, and everything else is going to be done in the home. So, pretty staggering predictions for healthcare going forward. Now, so how's the industry looking at this, looking at these kind of tectonic shifts? Well, a lot of technologies is evolving, whether it's for care coordination, telemedicine, remote patient diagnostics, remote patient monitoring. A lot of tech is being developed, but there's no one is looking at the workforce that's going to manage this huge tectonic transformation of healthcare away from the hospital to the home. So if you think about it, there's several different there's a hierarchy of people that provide healthcare at home. You've got your physicians that make house calls. Those are extraordinarily rare. You've got a few urgent care type of models where you have nurse practitioners and PAs that will go to a patient's home. Again, that's not a particularly efficient use of their time either. You've got home health RNs. And then from a home health RN, it goes down to like a home health aide, which is essentially a kind of a minimum wage employee that helps with chores and things like that. Between the nurse and the home health aide, there's a huge gap that I think medics can fill pretty much in a fashion that's similar to a home health RN. And so especially if you look at the advanced practice medics, the Army's got critical care flight paramedics, you got the SOCMs, you got the 18 Deltas. These are folks that work at a pretty high level that can do a lot, hands-on in patients' homes. And we think pretty comparable to nurses. Medic is one of the largest MOSs or enlisted job skills in the Navy and the Army and the Air Force. There's about 25,000 of them that leave the service annually. In the Army, if you look at the Compo 2 and Compo 3, these are medics that are in the reserves and guard that, again, they have no role in the civilian realm. So in other words, you can be a reservist and be a X-ray technician and still do your job, but there's no really such thing as a medic unless you're a EMT basic. And those are folks that are more focused on, loading and transporting patients, back and forth. So there's a huge potential workforce there between Compo 2 and Compo 3 medics, where we can train them to the paramedic standard and sustain them, either while they're in the Guard and Reserves or after they leave the service. And I tell you, I've been on the ground floor. I went to the basic medic course in 1987. At Fort Sam Houston, and I think I learned more in my Boy Scout First Aid Merit Badge class than I did at summer camp than I did as a basic medic student. I mean, it was pretty much sticks and rags, and that was about it. But now, you've got medics giving fresh whole blood on the battlefield, doing surgical airways, chest decompression, pretty advanced skills with TC3 that has really evolved significantly after 2 decades of continuous war. As opposed to EMTs, they're generalists, right? So they're doing, disease, non-battle injury, they're doing population health, they're managing preventive medicine, at these fire bases and FOBs, helping to take care of civilians, with a variety of different medical conditions. Highly adaptable, workforce that, again, I think can do pretty much things similar to what nurses can do in the home. So really how this, how we're looking at the opportunity now with COVID is, Medicare used to have a program, or they rolled out a program last March called the Hospital Without Walls program. And this was an extension of what Mayo Clinic and Hopkins, Johns Hopkins and some others had done, where they did basically experiments, controlled trials, where they allowed some patients to recover at home who otherwise would have come in the hospital for a few days, for simple diagnosis, COPD, CHF, diabetes related emergencies. So, they tee these folks up from the ER, make sure they got their durable medical equipment, and they'd send them home. And in the studies they found that patients did better, right? So, length of stay was reduced, 30-day readmissions were reduced, patient satisfaction scores were better. And then for elderly patients with dementia, that sundowning delirium that happens in the hospital was significantly reduced. And so if you've ever been in the hospital and tried to sleep, it's no wonder, right? Nobody, you don't get C. diff in your house or MRSA in your house, and nobody wakes you up at 2 o'clock in the morning in your house asking you if you want a sleeping pill. All that happens in the hospital. So people get better faster. Well, based on that and the COVID, last November, Medicare rolled out this program called the Acute Hospital Care at Home program, which for the first time recognizes community paramedics as a provider type. And so before, all Medicare cared about if you were a medic was, were you an EMT basic or were you a paramedic? And did you transport to the hospital or not? And that's all Medicare cared about medics. Well, so this community paramedic thing is very interesting because it's essentially a paramedic who has some additional training on dealing with acute or dealing with chronic diseases and diseases of aging, diabetes, high blood pressure, things like that. They're also trained in social determinants of health. So things like food security, home security, things like that. They can kind of synthesize all these factors together. And so the essence of our model is we want to take medics as they transition out, and again, recognizing there's a hierarchy of medics between an 8404 and a 68 whiskey and an 18 Delta. There's a significant kind of multiple layers and levels of medics. We want to take those medics and we want to transition them into the HomeFront Health team to the community paramedic level. And so for like your SOCMs and your 18 Deltas and your critical care flight paramedics, that's going to be, basically pretty much training you to be a community paramedic, work with those diseases of aging. For your 8404s and your 68 whiskeys, we'll take the EMTs as well. And then our plan is bring them on board as assistants to the community paramedics, and then give them a program whereby they can be community paramedics in about a year. So we'll be partnering with a lot of different people for internships and for apprenticeship programs and community colleges to help train to the community paramedic level. But there's a ton of folks out there in the VA and the Department of Labor and these state labor boards who really are invested in transitioning service members into good, high-paying jobs, and we think we can partner with them to rapidly grow a workforce that's really a unique workforce. And so what we're talking about at the end of the day is leveraging military medics to build a healthcare workforce that doesn't exist today. And we're going to use this acute hospital care at home program to kind of launch that. But we think that we can take medics, enable them with technology, and do quite a bit of care in patients' home, whether it's, keeping people well and healthy and out of the hospital, whether it's doing pre-op visits where we go in and do your COVID swab, run your EKG, get your labs, and then do a portable ultrasound to make sure you don't need to see the cardiologist, or to primary care, right? So if you do a telemedicine visit now, it's as if you go in the doctor's office and you sit down and start talking, but we can send a medic in with telehealth capability, get a set of vitals, address the chief complaint, do an exam, and then, use some remote diagnostic tools to basically get a better patient experience and a better exam for the patient as well. So, we think there's a ton of potential for this. It's an extraordinarily exciting opportunity to build a workforce that doesn't exist. And I would encourage everyone that's listening to go to our website, www.homefronthealth.com, and check us out. I'll pause there, and then if you want to dialogue with any other members of the team, we'll bring them in now.
Yeah, I'm gonna jump on and kind of add on a couple of things that I want to make points about in addition to what Bob said. I think there is a tendency as we start talking to this of, everybody's kind of familiar with home health. And I want to make sure that it's very, very clear. We are not home health. We are not, medics going in and changing bedding and rolling people over for decubitus ulcers. Our intent and the way that CMS is allowing us to do this now is medics are going to be operating really as that interface with the patient at the intervention level, at the level where you actually can provide meaningful input into that patient's life and truly change their healthcare outcomes. And I equate it to this, like when I was a unit surgeon and I had my patients that were in my organization, they would talk to me and I would see them on their visits, but I really had no idea what was going on with them. Like there was always a medic somewhere in between them and me that really knew the real deal, that really knew why they were having a problem or what their issue was, and had a pretty good idea of how to solve it. And it was usually when they hand delivered that patient to me with a thought process that the real care was truly delivered to that patient. And so I think that this model allows that to happen. Like these patients, they're going to be, medics' new team room, like you're going to be in their house. You're going to get to know more about them than their providers will ever have any, opportunity to know these patients on this level. And so I think in terms of being able to interface in such a meaningful space to truly influence healthcare in our society, the opportunity for this is a pure gold mine. I'm actually a little bit jealous. Like I kind of wish I wasn't a physician because I would love to be able to interface with patients on this level. So I really want to highlight how big of a role it is and how significant it is. When we look at healthcare problems in our country, so much of it is behavioral and so much of it is related to their environment and their home and their day-to-day actions. And it truly is somebody that can form that relationship on a personal level, not in the clinic, that will really influence healthcare outcomes. So I don't know, I'm really excited about that piece of it. And so I like to talk about that. The other piece is the training piece, because there's so much transition support out there. We really believe that, wherever people are at in their continuum of healthcare education and on their career pathway, we can really facilitate taking folks to the next level. And even if it's in transit to something else, we recognize different people have different career aspirations. It might be, all the way to medical school, or it might be, no, I just want to meaningfully interact with patients. I think HomeFront Health can really contribute to being a facilitator in that continuum of enhancing your healthcare skills and providing meaningful input in whatever community you're operating in. So that's just kind of what I wanted to share from my perspective. And I'll let the rest of the team chime in, but I'll be happy to answer any questions about that.
Yeah, I can offer a few things. First off, I want to say hi to Rico, Ricky, and Katie that are on there. So I'm going to wave to you guys. Katie, you don't have your camera on. So it's good to have like a little reunion almost a year later, seeing you guys. So yeah, thanks for joining us. And Katie and Josh, thanks for the opportunity to talk about this. And just on the coattails of what the two docs said, when I was a new guy at SEAL Team 2 back in 1990, I was told 3 people would go on a mission: the sniper, the radio man, and the medic. So I did 12 deployments, 4 of them were combat deployments, and there was always a medic, and I was usually one of the medics that was on there. In that same vein, you think about that often overlooked and underutilized resource of the military medics that get out. Their best day of getting out, if they don't find a job in some sort of medical field, is working at Home Depot or Lowe's, and pointing you to the lumber department, which there's nothing wrong with that. But I think it's just like Bob said, there's a huge underscoring of the resources that have been trained, educated, and developed, and then it just goes to the wayside. So the whole thing about HomeFront Health is looking at the underutilized and overlooked resource. And it's also to showcase any medic, not just the military ones, but the civilian ones as well. I mean, we're set up for intake for all military medics and civilian medics to come in. If you look at an hourglass and you turn it 90 degrees, you'll have all those communities coming in, and they bottleneck right there at HomeFront Health. And as Missy intimated to, is we're going to develop them to the HomeFront Health standards, because we have a standard, because we want to be the center of excellence for every medic to come through here. Then on the backside, if they want to be leadership within HomeFront Health and they meet the qualities, absolutely, the sky's the limit for what we're looking to do and how we're sorting it out. And then conversely, we want to set it up like Uber, like, say Ricky and Rico want to come in and do stuff for Katie, and they only want to work the weekends. We'll have them work the weekends, and someone else will take the day shifts Monday through Friday. So that's the concept that we're doing. It's like the Uber of medicine, but way more professional. And the biggest thing, and Bob and Missy said it, is we want people to age in place. We want them to be able to age in place gracefully, with dignity and integrity. And like Missy said, as a medic, people tell you things that they wouldn't tell their doctor and other stuff. So you can kind of really get the gist of what's going on. And for me, I just want to be able to emulate that in everybody, because seeing the work that Missy did in New York and how she pulled everyone together, it was very powerful. And everyone wanted to do the right thing for the right reasons. And you guys know, people will deselect themselves, when they start asking stupid questions like, how much am I going to get paid and where am I staying? Okay, stop. We're in a pandemic. That's not important. We've moved on from the pandemic. We're starting this business. We can tell you exactly what the structure is going to look like from start to finish. And we just really want to capture and showcase what the medics are capable of doing. They're good enough to deploy overseas. They're absolutely the right choice for being at the home front. And I'll stop there. And I think, if you have any questions, Katie or Shea, if you want to add anything to that.
For me, because I'm certainly the lowest guy on this totem pole, right? Like I'm the most recently separated from the service. I was an enlisted medic for 6 years. And when I got to my team, and most of you guys understand this part of it, like you get there and you're just trying not to fail every day. Like you're so swarmed with information that you want to perform well. You want to be a good team player. And it wasn't until my last year in the Navy that I had heard about anything like SOM+U or SOMA. And so knowing about any other program that would bridge my skills from the military to the civilian side was not even on my radar, certainly not until I had either just about got out or right after I out processed. And had I known about those things, I know that I would have taken advantage of a lot more than I was able to. And, we spent the last year basically working this project, and we have found multiple, like Bob talked about, state programs, federal programs. There has been, over the last 20 years of war, billions of dollars spent training all of us as medics. And there has not been a smooth enough transition program that has reached out down to those enlisted, especially junior enlisted medics, to hear about, to pull them out of when they do decide to separate, to pull them into the civilian sphere and let them start to practice as clinicians in the civilian sphere. And I just want it to be clear for those of you who don't already know, there's a ton of resources out there, and we want to be the one to provide it to you. We want to be able to take you guys in, plug you into exactly the track that you want to be on, and set you on that and support you through it. We've talked about the community paramedicine model. We've talked about paramedics. We've talked about taking EMTs or LVNs and people who have certifications that they either got while they're on active duty or are interested in getting, that we can help facilitate and training them up even further, or just facilitating their education and being supportive if they want to go to NP school or PA school or med school or whatever they want to do. We want to be a part of that, because we've spent so much time researching and making sure that we're prepped and ready to bring those medics in, give them the certifications, give them the training and experience they need to not just better themselves, but really better their communities, where we understand that a lot of the people that we're going to be bringing in are people who move back to their hometown. right? Or move back to, wherever they were from, or decided to throw down roots where they were last stationed and want to continue to participate in their communities. And this is really the opportunity to do that. So we have a fast and furious expansion program. We want to be everywhere tomorrow if we can. But the big component is being able to bring soon to be separating and recently separated medics in, to train them up and to deploy them immediately back into the field so they can start affecting change for patients. The shifts that we've seen in patients' desire to be taken care of at home, or to do things a little bit differently, especially since we saw so much shift to telemedicine over the last year, people realizing that a lot of the needs can be met, but there's that last little piece, that hands-on piece that medics are just so skilled at interfacing between the patients and the providers, like Missy talked about, and being able to feed them the information they need to provide better outcomes for patients, better experiences for patients, and to make sure that the providers are able to do their job as good as they possibly can. So if I'd heard about this, if I had known about all these things, I would have jumped on it. That's why I'm most excited. Like I got to learn all this stuff. I got to see all these things, and I'm really excited about being able to provide the opportunity for medics to get out and plug into a system that's already working, that's already turning, that's going to bring them from wherever they are right now to where they want to be next in their career as clinicians and as professionals.